I want to thank everybody for attending. Everybody understands that healthcare is moving fast. There's lots of debates on Capitol Hill, and it's important for us to talk about it, think about where it's going. Also, know a little bit about where academically we've come from in the past, and at the same time, where politically we've come from in the past. And so, hopefully, we can answer some of those questions today.
Folks, we're here today to discuss the three biggest problems with Obamacare that neither party is focused on or addressing in the Congress. Now, over on the Republican side, we have bills by Crapo Cassidy, we have a Marshall bill, we have a Scott Pfluger bill. These bills may have many good things in them, but they are not trying to address the three biggest problems that we have with the current system. What are these problems? On the buyer side, we're trying to force people to buy insurance that they're unwilling to buy with their own money. On the seller side, we're trying to force insurers to enroll people that they don't want to enroll. And on both sides of the market, we've created perverse incentives which causes people to do things that make costs higher and quality lower than it would otherwise be. So, 1, 2, 3. First problem is pretty easy to solve. Even President Trump sees how to solve it, and he doesn't have a background in health economics. Second problem is a little more difficult, but there's precedent on how to solve that one. Third, a little more difficult still, but again, we have precedent. We're not starting from scratch. Okay, so let's go through this. People being forced to buy something that they're unwilling to buy with their own money. We knew this was a problem from day one, from the very first year. Companies like McDonald's and Burger King were required to offer their employees insurance. They could charge 9.6% of the wages. I think out-of-pocket costs may have been $6,000 or $7,000. If they wanted to insure their family, they had to pay full cost for that. 95% of these workers turned these offers down. And not only did they not insure their families, they didn't even insure themselves, even though the subsidies were quite large. Now, in the years that have followed, the plans that they're being forced to buy have gotten increasingly unattractive. The premiums in the exchange have increased over the last decade twice as fast as employer premiums. The deductible today is twice as high as it is in an employer plan, typical employer plan. The out-of-pocket exposure is twice as high. This year, an individual can face out-of-pocket costs of $10,600, and it's twice that for a family. Now, why did we get the extended, enhanced subsidies that we're now arguing about in Congress? It really wasn't because of COVID, even though that's when it was passed. It was because the unsubsidized part of the market was in a death spiral. And healthy people were leaving, and the pool kept getting sicker, and the costs kept growing faster. Now, what's the solution? Well, President Trump sees the solution. Let people buy insurance that meets their needs. Let them have a tax subsidy, but don't tell them what they have to buy. The Kaiser Foundation says that most families could cut their costs in half by buying insurance that looks pretty much like insurance looked before there was Obamacare. So I would say 95% of people could have much lower cost insurance. Now, on the Democratic side, we hear the complaint that the insurance that people will choose, that they want to buy, is junk insurance. And what do they mean by junk insurance? Well, it doesn't cover everything. So let's suppose that someone didn't insure for substance abuse because he didn't think that was a problem in his family. And then he discovers, well, no, he made a mistake. He does have a child with that problem. Well, then Pete Sessions and I have an answer. Let that family go immediately to the exchange and enroll in a silver plan. And even maybe have a 30-day look back on the expenses. So we would let people easily move from the Obamacare market to other markets, go back and forth whenever health conditions change. And that's a solution that saves the government a lot of money, lets people have most of the time the insurance that they want to buy, and it protects them from adverse outcomes. Problem number two, what happens when you force insurers to enroll people they don't want? The reason they don't want them is because they have costs that are well above the premium that's being paid. Well, insurers react by trying to make their plans attractive to the healthy and unattractive to the sick. And how do you make your plan unattractive to the sick? You have a high deductible, you have high out-of-pocket exposure, which I just said was $10,600 for an individual, and narrow networks. So in Dallas, Texas, where I live, you cannot, with an exchange plan, go to UT Southwestern, which is one of the best medical centers in the whole world, actually. You can't go to Baylor Medical Center. You can't go to MD Anderson down in Houston, Mayo Clinic, Cleveland Clinic, all over the country. The best institutions are not taking this insurance. And just to give one example of what this really means, Blue Cross Blue Shield of Texas insures most of the state employees and most of the teachers in our state. And with that kind of insurance, they can go to UT Southwestern, they can go to Baylor, they can go to MD Anderson. But the same insurance company offers a plan in the exchange which is not accepted at those institutions. The same insurance company. Third problem. What is the solution to that problem? Well, we already have a solution in the Medicare Advantage program. Suppose you have a diabetic that's in such poor condition that he's at risk of having his foot amputated. That's a $100,000 operation. Well, in the Medicare Advantage system, there are special needs plans that advertise and solicit, try to encourage people to join their plan with diabetes and diabetes complications. And that's because we have a risk adjustment program which compensates them for their costs. We don't really have anything like that in the Obamacare exchange, and so no insurer exchange wants to attract a patient that has $100,000 of expected costs. All right, third problem, the perverse incentives. Most congressional employees are in the federal benefits program. The way that works is you get a fixed sum of money to assist you in buying health insurance. I think it's 75% of the cost of a benchmark plan, but it's a fixed number of dollars. And so then if the individual chooses among different plans, if he chooses a plan that costs $1 more than some other plan, that $1 more comes out of his pocket, not the employer's pocket. Now, in the exchange, we do the opposite. We put a cap on what people spend as a percent of their income, and once they go above that cap, they have no reason to care what health insurance costs. So if they choose a plan that costs $1 more than some other plan, that dollar is paid for by taxpayers, not by the person buying the plan. So on the buyer side, there is no incentive to control costs. On the insurer side, we've limited the profit of these companies to 15% of premium, and that's it. So if they find a way to make their plan more efficient and improve quality, that does not improve profit. The only way their profit can go up is if premiums go up. And so now we have on both sides of the market no real incentive to control costs, and of course they're not controlled. So what can be done about this? Well, the simplest thing that can be done about it is just copy what we've done for the federal employees. I mean, we know how to do that. There may be other things we want to do as well, but we're not starting with a blank slate. We have a system that's been around for decades. It works pretty well, and if we designed the Obamacare exchange that well, we would completely change the incentives. So with that said, I think I'll open it up if you all have a question or two before we go to Dr. Matthews.
If you can raise your hand, we will take a question or two, and then we will move on to Dr. Matthews. I see Aaron. Go ahead and unmute yourself, Aaron, and ask your question.
Yes. Thanks so much for being here. I apologize. I was taking notes and just didn't quite catch the solution that you had proposed to the first problem. Would you mind just sort of reiterating that one more time?
Sure. Let people have a subsidy, but select insurance that meets their needs. Insurance that is not Obamacare compliant. Okay. So it's policies that insurers designed to meet people's needs, not policies designed by the U.S. Congress. And that's essentially what President Trump is saying. Let's let them take the money and buy insurance that meets their needs. And the short-term market, which Michael Cannon will talk about in a minute, is a market where you can cut the premium in half in most cases. So the premium goes down. The insurers have to compete on price and they have to compete on quality. I
All
might
right.
add. Go ahead.
Nothing. We have time for one more question, but you can add.
Well, I will just add one other observation. Um, when some Democrats claim that the insurance that people want to buy is junk insurance, what they sometimes mean is, well, what if they had $1 million premature baby? What then? And the answer is that people who work for a fast food restaurant are never going to buy with their own money a plan that covers $1 million premature baby. And they're not going to do it because they don't have $1 million to protect, on the one hand. And on the other hand, in the rare case when this might happen, they know the hospital is not going to throw the baby out on the sidewalk, and so the baby is going to get medical care. So they are not going to buy that kind of insurance. But we want something to be done for that baby, and so the approach I'm suggesting is let people buy the insurance that they want, and insurance they're willing to pay for that meets their needs. And the whole reason for the government is to provide a safety net, to provide coverage that people are unwilling to pay for themselves.
All right. Thank you. Oh, yep.
Sorry, I'm not sure how to do the raise my hand
Raising
on
the
the.
hand. You're
I'm
good.
sorry about
We
that.
got you.
So I'm curious with this, John, great presentation, and just curious about how this works with stop loss and lasered exceptions. So I'm not thinking about the child who's the NICU baby. That's truly, to me, what traditional insurance is meant to cover, sort of that unanticipated expense. But I'm thinking, like, for example, the kids with hemophilia on Hemlibra.
Well, what I'm suggesting is that if people don't insure for it themselves, and for rare diseases that are expensive to treat, very often they're not going to do it. And so that's why we need a safety net. Well, the Obamacare exchange right now is that safety net. So if people can always go there for everything that Obamacare covers, then that's your stop loss. That's your safety net. And so I'm not proposing that we get rid of Obamacare. I'm proposing that it remains there for needs that are not met in the private market.
Exactly.
All right. And we will have time at the end for some questions as well, but we wanting to continue working through the ideas of the academics on the call. Dr. Merrill. Merrill, will you go ahead and let us know what you're thinking?
Thank you all for joining us. And my goal here is to talk about expanding HSAs for everyone. So a little background here. Health savings accounts started as medical savings accounts. Dr. Goodman is considered the father of medical savings accounts, which became HSAs. But I think he published the first study on it in 1992, passed as legislation in the HIPAA legislation in 1996. Went from medical savings accounts to health savings accounts in 2003 in the prescription drug benefit legislation. So he's been doing this for a long time. Just to give you a little background of how they've grown, about 40 million HSA accounts are active right now, and they cover about 60 million people. 64% of those people live in zip codes with a median income below $100,000. And for age 55 plus, they have about 65 billion in accounts, and the average balance is about $6,500. That comes from the American Bankers Association, which tracks this. So that gives you a little an idea of how broad they are right now. The one big beautiful bill actually expanded HSA, so we were glad to see that. They made some good provisions there. So lots of people have access to them. What I'm going to talk about is how we might expand them to Medicare and Medicaid. So I am in a Medicare Advantage plan, Humana, and when I signed up for the plan, I got a card here, which I'll show you like this. So it's just like a debit card, and they included on that $75 a quarter that I could use to go out and go to drugstores, CVS, Walgreens, Walmart was all covered in that. And I could use this to buy certain covered over-the-counter drugs, and it would be paid for by my Humana card. And I thought at the time, this is kind of like a mini HSA because I'm able to go out and buy things with my own money here and use it. And it forced me to comparison shop. My wife was in the same plan, so two together, we had essentially $300 a year, $75 a quarter each to buy over-the-counter drugs. You would be amazed at how consumer conscious we became with just $75. So we're looking at what we can buy at Walgreens. Is it a better price than what we get at CVS? We can go to Costco and buy something out of pocket because it has a much better price, and we'll use the card here for something else. We became real value conscious shoppers in the healthcare marketplace. And I thought at the time, what if this was changed a little bit to expand it to something that worked more like an HSA? So instead of getting $75 a quarter, I'll just pick a figure. Maybe I get $500 a quarter, or maybe $1,000 twice a year. And with that money, I am allowed to go out and buy over-the-counter drugs, but I'm also allowed to buy prescription drugs at the discounted price that Humana has negotiated. Or I could go to a healthcare provider, to my doctor, and pay the discounted price with my card, just like I was paying cash. Because when I used the card, I would go up to the counter at the drugstore. They would ring everything up. I'd hand them this card. They would run that through, and then I'd pay the balance with another card. So what if we had something like that in Medicare? What would that force us to do? Well, if you did something like that, you would have people begin to think, how do I get value for my health care dollars in Medicare? We have been trying for some time to try to get healthcare providers to post real prices. It never really worked. And the reason it doesn't work, and Dr. Goodman mentioned this, is because I don't pay for that. I pay, excuse me, in most cases, I pay a copay. So if I go to the doctor and the doctor's charging the insurance companies $100, $500, $1,000, as long as my copay is $35, I don't really care what the doctor charges. If you had a card that you could pay for essentially like cash for those basic charges, you would begin to ask the question, doctor, how much does this visit cost? And you might go around and look at a few other doctors in that network to see how much they charge for it, and begin to try to find out where you got value for your money. We would encourage this, and this is true in the One Big Beautiful Bill. You can use this for direct primary care, direct pay. So you could use it for a range of different basic services, for routine and basic healthcare services, to encourage people to begin to be real conscious, value conscious shoppers in the healthcare marketplace. So you could do that with Medicare. Could you do it with Medicaid? And the answer to that is yes. About 75% of the people on Medicaid are in a managed care program. Basically, they get their health insurance through a managed care program. The state pays a capitated price to the managed care program. So what if to those lower income people in Medicaid, you said, we're giving you a card, and on this card, you've got a certain amount of money that you're going to be responsible for, and this money belongs to you. Under this Humana card, if I didn't use it by the end of the quarter, I actually lost the money. So it encouraged us to be wasteful spenders to make sure we spent all the money by the end of the quarter. But what if that money rolled over and I could then use part of that money in the next quarter or the next year? So if you did something like that, you would have lower income people in Medicaid beginning to be value conscious shoppers again, as they're trying to get the maximum value out of what they have for that money. So we feel like moving to something like that in both Medicare and Medicaid would greatly expand the programs, get people thinking about the prices and what they're paying, and would encourage them to be able to comparison shop out there and begin to demand real prices. We talked about prices, Dr. Goodman did. You're not going to have medical providers, hospitals, doctors, others providing real prices for things until consumers demand those prices. And they're not going to demand those prices until they have an economic incentive to try to make sure they're getting value for their money. So with that, I will end.
And I will actually take the first question because I think that that's an important statement that you made at the end. Can you, there's a lot of thought about having, I call it forced transparency, but there's transparency bills on Capitol Hill. Can you expand on the thought of how those work or don't work as we're currently seeing options?
Yes, some states have already passed transparency bills, and in many cases, the hospitals just largely ignore them. I can't remember the exact figure, but a large percentage of hospitals just haven't gone to do that. And what you might actually have on something like this, one of the things you should realize is the prices in healthcare are largely shams, and sometimes when you're paying out of pocket, it's actually less than the insurer. So, an example, I have a prescription fluoride that I use. Don't tell Robert Kennedy that, but I use a prescription fluoride, and I've been using it for years. I went to the pharmacist a little while back, and I was going to pay, I think it was a $15 copay, and I said, just out of curiosity, what if I didn't have insurance? How much would it cost me? Then he went and looked at his computer and said $7.50. And I said, you mean if I pay just out of cash, I just pay out of pocket, I can get it for half the price of my copay and not even include the insurance company in that? He said yes, and so that's what I've been doing ever since. What I think you might see happen is doctors, instead of doing a bunch of listed prices, because insurance companies negotiate prices and those are all different with every insurance company and doctor, is that a doctor might just give you a cash price. And this happens in other areas of the economy. If you pay with a credit card or something, you pay a little more. If you're going to do a cash price, you get a flat price that you can pay for directly, and that allows them to bypass a lot of the insurance and other things. So I think you would get a cash price for that. So if you're not going to get if once you get the system and consumers demanding prices, and remember, when you walk into a drugstore, you walk past all kinds of over-the-counter drugs that have prices and sales and everything else. You walk up to the pharmacist and say, how much is this drug going to cost me, this prescription drug? The pharmacist can't tell you. He'll have to go look and see what your insurance is to find out what that price is and tell you.
One of the interesting things is, and raise your hand if you have a question for Merrill. We have time for one or two questions. I'll get to you in a second, Dr. Goodman. There's we call them islands of excellence, but there are places like the Surgery Center of Oklahoma that list their prices and they're like cash, or Dr. Josh Umber, who's a DPC, who you can buy your medications through him and prescribed from him and delivered from him at a much cheaper at the cash price. He's actually giving it to you at the wholesale price.
That
So it's
Yeah,
out
that's
there.
that's right, and that's why we suggest that primary care should be part of this, because for primary care physicians, when you pay that monthly or quarterly fee, it covers most of the cost of seeing that doctor. So that's one way where you can get an upfront price, and then you get sort of like having a retainer, and you get a lot of services then covered for that. So that's another option there. But the market will figure out a way to get prices. And one of the things we used to talk about at the NCPA, cosmetic surgery. If you're going to get cosmetic surgery not covered by insurance, the cosmetic surgeon can oftentimes give you a package price of how much it's going to cost to get that tummy tuck or chin lift or whatever. But when you go to the doctor to get surgery, they oftentimes can't tell you the price of it, and you get a huge list of things that's dramatically discounted because of the insurer's discount. It is an unworkable system right now. The only way you're going to make it work is for consumers to be able to demand those prices.
All right, Dr. Goodman.
Well, I would just add that in every market where producers are competing on price, the price is always transparent. And the reason they're not transparent in the hospital marketplace in the United States is because hospitals don't compete for most patients on price. But if you're Canadian and you're coming down here for joint surgery and a joint replacement, knee replacement, hip replacement, they do compete on price. And so the Canadians always know what they're going to pay before they come down here. And these are the same hospitals that will not give you a price because they're not competing for you on price.
Excellent. All right. Well, let's move over to Michael Cannon over at Cato. I just realized while we were talking, we have it's like four generations of NCPA here. John, the founder, Merrill, the employee, Cannon went there, and then I came up fourth. So this is a little healthcare history lesson as we go through. I didn't give John's full introduction as the father of health savings accounts, but I think that it explains we all do have a similar mind to this. And so, Michael, you recently got some support from the president. So I'd like to hear what you're thinking and where you're going.
So thank you. Thanks for having me on. Especially thanks to John for all that I've learned from him about health policy over the years, starting with this book right here. You may notice on my shelf behind me, the binding on that book, John. It should look familiar. That is Patient Power. That is John's magnum opus that he wrote for the Cato Institute back in, I think it was 1992, that really put health savings accounts, we were calling them medical savings accounts at the time, really put those on the map, made it a household term, and 10 years later, Congress had enacted them. So, yes, I've worked for John at NCPA, and I've worked with him in the decades since, and thanks for the opportunity, especially to talk about a particular aspect of the health insurance and health policy challenges that are facing us. John mentioned short-term plans. Really, the issue there or the opportunity there is to expand people's ability to make their own health insurance decisions and then let market innovation and competition do the rest, letting them make health care and health insurance more affordable and more secure for people. And so I'm going to say a little bit about that. And then I hope at the end, maybe a little bit about what to do about the folks still in Obamacare, Medicare, and Medicaid. So right now we have, as John said, this problem where a lot of people are struggling to afford, all types of insurance, but particularly Obamacare and employer-sponsored insurance. And the solution or the answer, it's not really a solution that Democrats have offered is, let's give people more money. Let's give insurance companies more money to hide from people the cost of Obamacare and all of its regulations. And that's not really a viable solution. We already spend more money than other nations do on healthcare. If we just throw more money at the health sector, prices are going to go up even more, and wasteful consumption is going to go up even more. That's not imposing any discipline on a sector that badly needs discipline. There are alternatives, however, and President Trump showed us what one of those alternatives is. It's a very viable one, which is to allow, as John said, people to buy insurance that is exempt from all of Obamacare's regulations. There is a market that does that. Congress created this exemption from federal health insurance regulations for something that Congress called short-term limited duration insurance. More about that in a second. But that exemption has been there since 1996 when Congress first got into the act of regulating health insurance, the individual market anyway. And when Congress passed the Affordable Care Act, it left that exemption in place. So none of the Affordable Care Act's regulations apply to this market. Now, this market only allowed plans to last about 12 months, and then President Obama shortened them to 3 months. Well, what President Trump did is said, you know what, those are barriers to consumer protections. When you say that an insurance company has to kick someone out after 3 months, a longer insurance contract is a consumer protection, a renewal guarantee that says you can renew, we will guarantee that you can renew when that first contract ends, and that we won't underwrite you. Even if you get cancer, you'll pay healthy person premiums. Those are consumer protections. So the Trump administration said, let's change by regulation, change the way the government interprets that exemption and say that those plans can last up to 36 months. And there's nothing in federal law the Trump administration specified prohibiting an insurance company from also selling you a renewal guarantee. The federal government doesn't have any authority at all to regulate renewal guarantees. So the Trump administration said that. 2 federal courts upheld that existing federal law already provides enough flexibility for that supposedly short-term market to offer long-term insurance protection. Because as long as the insurance is short-term, a renewal guarantee can let you stitch together multiple short-term plans and essentially, as the court said, provide long-term health insurance protection. The best part might be what the Congressional Budget Office said about this option. They looked at these options and said, as John noted, that these are basically the plans that people had before Obamacare that they wanted to keep. These are the individual what insurance companies started offering for that period when after Trump changed the rules in 2018, all the way until Biden revoked the Trump rules in 2024. They were selling pre-Obamacare individual market plans, the plans that people were telling us they wanted with their dollar votes before Congress passed Obamacare, and then telling us with their actual votes that they wanted back after Obamacare threw them out of those plans. So they had those plans, and what the Congressional Budget Office said when they studied those plans is they said, hey, the premiums here are 60% less than the lowest price Obamacare plans. So most people in the exchanges could leave the exchanges and afford health insurance on their own without the need of a government subsidy if we would just remove those barriers. But not only that, those plans offered broader provider networks. They offered lower cost sharing than a lot of Obamacare plans. And if you look at another spot on my shelf, behind me, you'll see a young girl named Colette Briggs. Colette Briggs is one of the types of people, one of the people who got caught up in the perverse incentives that John was talking about that lead Obamacare plans to exclude cancer centers and other top providers. Colette Briggs got a leukemia diagnosis at age 2, and repeatedly her Obamacare plans, the Obamacare threw her family out of its pre-Obamacare individual market plan, left them in the Obamacare market, and because of the perverse incentives in Obamacare's pre-existing conditions rules that John was talking about, which are basically rent control for health insurance, the quality of those plans got worse and worse, and the plans kept dropping cancer providers from their networks. They kept trying to switch plans, and successive plans would do this, and it got very, very difficult for Colette to get the cancer care that she needed. If you let people buy insurance in that is exempt from Obamacare, they'll be more like those Blue Cross Blue Shield plans that John mentioned that do cover the cancer centers. So you'll be providing better quality health insurance to people at a lower price. And if you get people into those Obamacare exempt plans and they provide long-term coverage, then after those folks get cancer, they'll get more secure access to the providers they want, so better health insurance. But also, if they have a renewal guarantee that says your premiums won't go up because you got cancer, you'll still pay healthy person premiums, they won't want to go back to Obamacare. They won't need to go back to Obamacare. We will be keeping cancer patients and other people with expensive medical conditions out of the Obamacare pools, and that will improve the performance of Obamacare, help keep those premiums down, and reduce the burden of Obamacare on taxpayers. What Congress has to do to make all this happen is they need to codify the rules that President Trump put in place in 2018 that allow people to get premiums that are 60% lower with broader provider networks and lower cost sharing. Codify those rules, make them permanent, because President Biden took them away. And even though President Trump could do right now what he did in 2018 and put those same rules in place, another president could come along and undo it. But if Congress codifies it, that will give the market, the insurance companies, the regulatory certainty they need really to invest in this market, provide renewal guarantees that provide that long-term coverage. And there has been legislation in Congress. Senator Ted Cruz has introduced legislation along these lines. Others have introduced legislation that would codify those rules. And I think that would be to the benefit of consumers in the individual market and people in Obamacare because it would reduce premiums there. As for, I think that would largely go a long way to solving some of the problems that we see in Obamacare. I'm not a fan of the president's proposal to take the money that Obamacare is giving to insurance companies right now and give it to individuals. I call that a bad take on a great idea. I think that in Medicare, it does make sense to do that. In Medicare, you won't get much of a woodwork effect. Just about everyone who's eligible is already enrolled, and so spending won't go up because of a woodwork effect. What we should be doing is taking the risk-adjusted payments that Medicare makes to insurance companies and saying, hey, we're basically mimicking actuarially fair market premiums for health insurance. That's the subsidy that we're getting the insurance companies for covering these Medicare enrollees. Once we've done that, there's absolutely no reason not to give Merrill the entire amount that Medicare is paying an insurance company on its behalf as cash. Turn Medicare into a Social Security-like cash transfer program that just gives the seniors cash and trust them to spend it like Social Security does. Give sicker people, as I mentioned, larger Medicare checks, and maybe even give lower income people larger Medicare checks so that higher income people get smaller checks. They don't need it. That's fine. They will spend that money much more wisely than Medicare does or they do when it's Medicare's money. You can do the same. However, if we do the same thing in Medicaid or Obamacare, there would be a big woodwork effect that would increase government spending on both of those programs. In Medicaid, at any given time, only about 2/3 of eligible people enroll. And so you could increase Medicaid spending by 50% if you give people cash and make the Medicaid subsidy more attractive, because a lot of people who won't cross the street for Medicaid will cross the street for cash. The same is true in Obamacare, except the number of people potentially eligible for Obamacare subsidies is 4 times the number of people who are currently receiving them. You could get a very large woodwork effect there. I think the better strategy in Medicaid is you fix that with block grants. The better strategy in Obamacare is you give people alternatives, Obamacare exempt plans. And that is how we make healthcare better and more affordable and more secure for the maximum number of people in the best politically feasible way.
Awesome. Lee Curry, clapping for you.
Thank you, Lee.
I think it's great. I do want to, at some point, I want to debate the woodwork effects with you. But right now, I want to ask you about the guaranteed renewability. How did that work? Like, let's call it pre-Obamacare, and how do those work now? Like, you can't just get it a guaranteed renewal in infinity, right? But I'm not sure how it works, so I'm actually asking.
Well, no, because you're not going to live forever.
Yep.
Yeah, so infinity doesn't work here. However, renewal guarantees can provide cradle to grave coverage. And it's not just that they worked before Obamacare, they're working right now in Germany. There's a study recently that looked at, in Germany, they have what I'm talking about, which is a voluntary insurance market with market prices, so actuarially fair premiums, and they offer renewal guarantees so that if you get sick, you can stay in your plan. You can re-enroll when the contract expires. They guarantee that. And your premiums will not go up to reflect your illness. And what economists have found when they look at these plans is they come within 96% or within 4 percentage points of the socially optimal outcome. That is remarkably close to economic perfection. If there's a market failure there, it's maybe 4% of total spending, which is very small for market failures. And you don't need to upturn an entire industry to correct that sort of a market failure the way that Obamacare tries to do. So let people have that freedom. They will purchase the plans that they like. They'll, I think, get better coverage. And I mean, I can give a whole presentation on renewal guarantees and how they work and how they emerge in the market and how markets are still innovating, how insurance companies used standalone renewal guarantees to fix the enormous gaps that the government created in the employer market. But I'll close my answer on this point, which is about junk coverage. Every time we talk about Obamacare exempt plans, people lambast them as junk coverage. You know what is junk coverage? The Medicare program is junk coverage. Employer-sponsored insurance is junk short-term coverage because these programs encourage low-quality care. They encourage higher spending and higher prices. Medicare doesn't limit out-of-pocket liability or liability at all. And the employers based system that the government favors with a huge tax preference or penalty, depending on how you want to look at it, that drops people after they get expensive medical illnesses all the time. It fuels the problem of pre-existing conditions, as well as making healthcare and health insurance more expensive. Once you get sick, it throws you out onto the market without any protection from those prices that the employer-based system drives up. These are junk plans. What we're talking about is insurance that insurance companies tailor to what you, the consumer, want and provide you the kind of protection that you want and the access to medical care that you want more than Obamacare does, which is, by the way, also junk coverage. Just ask Colette Briggs.
Thank you. Merrill, you were raising your hand and I muted you, so you're currently muted.
Okay,
There you
yeah,
go.
thank you. Yes, I just following up on what Michael said. I am fine with us putting money into a Medicare, so just giving people the access to the money. In fact, I would go if in my perfect world, I'd go even further and just have people instead of paying the payroll tax, they'd put the money aside in an account, and then when they retired, they'd have the whole amount of money. They could choose what they wanted to spend that money on. My concern is especially on the Trump's suggestion that you take the Obamacare subsidies or just the money and just give it to people. I like that idea in theory, but talking about the woodwork effect, people would come out. And here's the problem I'm concerned about. We are realizing now, it's been a case for a while, but we've got serious fraud in Medicare and Medicaid. And if employers were to take money and put it into a large HSA where employees could then buy an employer plan or go out and buy their own health insurance, that's sort of being monitored by the employer. If I'm putting my own money in an HSA and then deciding how I want to spend it, that's my money. When you're taking taxpayer dollars and putting it into Obamacare, and you give me an option to go in there and I get a lot of money, we have people out there who will find ways to engage in fraud with that. So until we need to get a better handle on how we handle Medicare and Medicaid fraud and just health insurance fraud before we get too generous with how we handle the money, I think.
I think that's a great point. In every government program, we have intolerable amounts of fraud, but the fraud in Medicare and Medicaid is much greater than in the Social Security program, just because Social Security is simpler and easier to monitor than Medicare and Medicaid are. And so I think we could reduce the problem of fraud if we turned the Medicare program into a cash transfer program, because it would be fewer transactions. Instead of billions of transactions every year, there would be 70 million, because Medicare would write 70 million checks to enrollees, and that's it. And on the Medicaid side, well, the best way to combat fraud in Medicaid is to switch from the matching grant system of funding states to a block grant, where states are on the hook for 100% of the costs of every fraudulent expenditure and every fraud scheme. Their incentives to police and root out that fraud will be much greater when they see 100% of the savings. Right now, sometimes 90% of the savings, and sometimes even more, goes to Washington, D.C. And so why invest in fraud prevention?
Great. All right. We have a question in the chat, and it's for all three of you. However, Michael has already answered it. So it's from Phil Kirpin. Should Congress mandate the cash pay services count against deductibles and out-of-pocket caps? Michael's answer, no.
You don't even have to read past the word mandate. Should Congress mandate? No.
That's where I go to. But Merrill or John?
Sure, I wanted to offer a more moderate approach to health savings accounts in Medicaid and in Medicare. There's something called a cash and counseling program that's several decades old, and Medicaid puts money into an account for the homebound disabled people, and they manage their money, and they can hire and fire people who work for them. Satisfaction rates are really high, like in the 90 percentile, and it's been going on for some time. It's always seemed to me that's a good model for introducing health savings accounts in a broader way. So instead of just giving money to people, as we've been talking about, a more moderate step would be to allow the managed care companies to put money into an account if the beneficiary agrees to handle a certain type of care and handle all the expenses, but benefit if good choices were made on spending that money. So, for example, it might be all primary care. So if the enrollee agrees to pay for all primary care from his account, if he exhausts the account and goes over, it comes out of his own pocket. If he's careful and doesn't spend all the money, he gets to keep it at the end of the year. So now we haven't put any new money into the system, but we've allowed the insurer and the beneficiary to come to an agreement. And the best opportunity for primary care is the direct primary care, which people used to call concierge medicine. But in many parts of the country, the price of that's come way down. In Wichita, which is where the current model started, it's $50 a month for a mother, $10 for a child. So if the managed care company put money into an account for that mother, and for those dollars, she gets the doctor's phone number. It's 24/7 care, and then and she's managed her money. So right now, it costs Medicaid more if we go to the emergency room in Dallas than if you go to a minute clinic. But the beneficiary doesn't know that. If it's the beneficiary's money, then that person would know that going to the emergency room costs more than going to a minute clinic or an urgent care clinic, and so they would have incentives to keep down costs. Right now, when people join Medicaid, their trips to the emergency room increase by 40%. That is not medically desirable, and it's not economically desirable.
And just to add to what John was saying there, Michael and I are going to agree on a lot of things here. We're just both talking about something and using this card where Humana manages the money, and so it would be much more difficult for me to commit fraud with this card than it would be if I just have an HSA. But what
You
we're
keep
talking
flashing
about,
that card, I'm going to commit fraud using the numbers on that card.
what we're talking about is if you're taking steps. So we may not be able to get to where we'd like to go, Michael, but we may be able to take some steps to get us that direction. And what John is talking about would get us moving in that direction so that you can say, here, this works. Now we can expand it even further.
And Michael, I have something to add to your answer, but there was a question in the chat. It's could you repeat how to prevent fraud with Medicare again? And you answered that. Can you just give a brief overview? So we are recording this. I think
Sure.
your answer is really good, but I think that there's from Keith Smith, his prices kind of show what you're talking about there.
Sure. So the biggest problem is an incentive problem. No one has an incentive to police fraud in government programs as great as their incentive to help police fraud in private sector transactions where it is their money involved. The example I like to use is you go to the gas pump, and it used to be the case, I'm not sure it still is, where you try to pay with a credit card and you have to do what? You have to put in your zip code. Putting in your zip code is an anti-fraud measure. It's to guarantee that or it's to help assure that the person who's using that card is the owner of that card, because your zip code doesn't appear on the card, or to know the zip code suggests that you're not someone who just ripped off, stole someone else's card. And that's an inconvenience to put in your zip code, but we tolerate it because it's not much, and our credit card interest rates would be higher if we didn't because of the additional fraud. We're not willing to do that when it comes to government programs. We're not willing to put up with inconvenience because it doesn't save us money. It saves other people money. And so when doctors have to comply with measures designed to prevent fraud in Medicare, they don't like it. They push back, they lobby against them, and they get defanged. And so that's the big reason. And that wouldn't go away under a Social Security type reform of Medicare, where Medicare is just giving people checks, because there's still that kind of fraud in Social Security, excessive fraud. But the fraud would be much less because of the other reason. A huge difference between Medicare and Social Security is Medicare conducts billions of transactions every year. Medicare is basically like millions of ATMs all across the country, and all that providers have to do is punch in the right numbers, and Medicare spits out cash. Insurance companies too, they punch in the right numbers, Medicare spits out cash. And it's really hard to police a billion or billions of transactions like that. That's why fraudsters can get those numbers, put them in, and take that cash out, and the money, and they will be gone before Medicare catches up with them. It is much easier to police just 70 million transactions like Social Security does, where you're just writing one check basically to every enrollee instead of multiple payments to providers on behalf of an enrollee. Again, not tolerable levels of fraud, but much lower levels of fraud.
We'll get to you in 1 second, Dr. Goodman. And because of that, the Medicare spending is increasing, or prices are increasing faster than GDP. If we look at Keith Smith in Oklahoma, he first listed his prices in 2009. The first price movements he had were 5 steps down. He kept decreasing the price of his healthcare as he was going, and he has increased it twice, but I think it's for a total of a 10% increase. So from 2009 to now, he went down and then came up 10%. So, and his last price increase was, I believe, 2023. So where you have people that are competing on price, we have a different level, different competition in the economy. Dr. Goodman.
Sure. Think how often you give your credit card or one of your credit cards to somebody else. Think about how often when you're at a restaurant that somebody else disappears with your credit card. So you'd think that the opportunities to commit fraud with credit cards are just all over the place. But the fact is that the credit card fraud rate in that industry is less than 1%. And sometimes I have just humorously suggested, why don't we just contract out to the credit card industry to handle our fraud problem? But more seriously, the point is that we know how to prevent this, or somebody knows. And so using the same techniques that the credit card industry uses, instead of 10%, we should be down around 1%.
In the chat, Anne-Marie Schreiber asked, do any of the panelists know why Medicare Advantage companies do not offer Medicare savings accounts, which are allowed by law? Should Congress or CMS require MA participant payers to offer enrollees such an option?
We did publish something on this in the Cato Journal some years ago when the Medicare MSA option was still nascent. What that article found was that there was no the way they wrote the rules, there was no situation in which it is both the interest of the health plan and the enrollee to enroll in or to avail themselves of that option. And I think that might be just as well, because my answer to the question, should Medicare require them to offer these options, is probably not. And it's for a similar reason as before. If you give people a new type of subsidy in the Medicare program that they can choose, like before we had before we had Medicare Advantage, there was just traditional Medicare, and then we gave them this other option of Medicare Advantage. That giving them that additional option tends to increase Medicare spending. Medicare Advantage certainly has. And I think if we add on a Medicare MSA option, it probably will as well. The reason being, the amount of the subsidy is never going to be the same across all these options unless you just give people cash and then let them choose. That's how you equalize it. But if you've got one set of complex formulae figuring out what the net subsidy is going to be over here, and then another one here, and then another one here, people are going to gravitate to the option that gives them the biggest subsidy, and just naturally, that's what they're doing with Medicare Advantage, and that's going to increase Medicare spending even more. So I think the way to encourage price consciousness, medical or health savings accounts in Medicare, is to do what I mentioned before. Just give the enrollees the cash, a risk-adjusted amount, let them choose what their deductible is and how much money to put aside for out-of-pocket expenses and that sort of thing. And we'll get to the exact same place that we're hoping to get with the sort of a mandate approach.
Let me add in that in talking with Beverly Gossage, who's a state senator in Kansas and also a health insurance agent, she has one of those, and she mentioned that one of the problems is that when you go to the doctor, the and you're checking out, they don't understand this. And so you're trying to use your Medicare MSA account, and they want to charge you the full price rather than the discounted price that you would get from insurance. You end up having to argue with them. Sometimes you have to pay the full price and let them give you a discount. She said it just did not work very well from that standpoint. So you had to know what you were doing, and that makes it more difficult.
All right, we have time for one more question or some concluding remarks if any of you want to close us out. Aaron, you want to ask a question? Thank you.
Yes, please. This is originally for Michael, but I'll take anyone's answer on this. Um, the majority of a person's medical needs occur in the last quarter of their life, as do the complexity of care needs, which sort of speaks to what you were talking about earlier and the uptick of doctor's visits after enrolling in Medicare. So, given those increased needs, if Medicare did get transferred to a cash transfer program, how do you propose determining the value of those checks that would cover patients and their needs without it becoming more expensive than just reimbursing the care actually used?
Great question. How do we do that now? I mean, insurance companies are doing that now in the Medicare Advantage program. They are providing health insurance to Medicare enrollees, and they're doing it for the prices that Medicare is currently paying them. The way that Medicare comes up with those prices is really dumb and convoluted. They take how much Medicare spends on traditional Medicare enrollees, and then they do a bunch of complex things, and the insurance companies can game it. And then they add money to the payments to the insurance companies if a particular enrollee has certain illnesses. And then they send the insurance companies a check. And the checks are smaller for healthy people, larger for sicker people, and the insurance companies then provide them coverage. It doesn't work perfectly well. There's a lot of perverse incentives in there. What we talked about with regard to Colette Briggs and what John was talking about under provision to the sick, that happens in Medicare Advantage. But the money isn't the problem there. It's the incentives. If we take the same method that Medicare uses to determine the amount of money that they give to Medicare Advantage plans for covering Medicare enrollees, and instead give that to just straight to the enrollees, that's plenty of money for them to buy health insurance for the rest of their lives. And Medicare Advantage is the proof. So plus including all the wasteful spending in traditional Medicare and additional wasteful spending in Medicare Advantage, there's plenty of money there. Whether those payments would be adequate is the least of our concerns.
All right. I want to thank everyone for coming. Given that we are on Zoom and can't give a round of applause to everybody, I will just thank you for everything. I think Dean Clancy said it in the chat. Great webinar. Thank you all for your time. Hey, there's some claps. If anybody has more questions, let us know. We can get everybody to answer it for you, but thanks everybody.